wondered coming in if the weather was gonna impact.
I don't think any of us.
By 8.
Yeah, I don't think any of us were expecting.
Oh, it sounded like, we might get a little bit, but it was mostly gonna be north and. Although I'll take it over the ice.
Yes, absolutely.
And it's making it easier to walk dogs on a nice yard, so I'll take it too. But.
Do we have some on Zoom, Russell?
We have 2.
Okay. Letting the Zoom people know we're a little delayed. We'll be coming at you soon.
Hey, how are you?
I thought you were in 203.
Oh,
I was sitting there all day, I'm like, where's Scott? Yeah, we're grabbing all the papers, sorry.
Oh, no problem. No problem.
Well, I thought you were muffin these then, because I thought they were for us.
How are you doing?
Good, how are you? It's nice to
Good.
see you in person.
Yeah, right. Nice to finally acquaint.
Right.
When we speak, do we need to stand near that so we can be heard, or is it coming through the webcam?
It's there's a mic in the camera right here.
Oh, excellent. Okay.
They'll fix it.
Oh, that's all right. We made it. Right?
We did, yeah.
So Johnny, for your slides, I just have yours. right
This is
after us.
what-
That's what it looks like.
So
Oh,
basically,
well, I don't need that
reference
camera.
slide.
Oh, come on.
This is, it's on PDF, but it looked like it's still got the animation.
Oh,
for your slides and stuff.
Okay,
Yeah,
okay.
so it should all work exactly how we want it to.
Perfect.
Are we ready?
Yeah.
All right.
Awesome.
So good morning. My name is Megan Bullard. I am a member of the Hatched Planning Team. So I will be monitoring the time today. The session will be recorded for future use. And so it is my pleasure to introduce Gail Bullard, Scott Sexton, and Jonni Williams, addressing the substance abuse disorder crisis, innovation and collaboration in a rural community.
Yeah. Virtual participants.
You understand?
Yeah,
that
probably
on that
works.
side of the camera.
All right. Good morning and welcome to our community collaboration and community change presentation for Cameron. This morning, we're going to walk you through some objectives, and hopefully you'll walk away with knowing a little bit more about the opioid crisis and how it's impacting us in this community, and the work that the Central Michigan Recovery and Education Network, known as CAMRON, a federally funded grant program at Ferris State, is doing to address that community crisis.
Can you stand on that side?
Which side?
That side of the-
Sure.
Then you'll be in the picture.
Oh, okay.
All right. So before we get started, we do just want to share some statistics with you all. And just to note that behind the numbers, there's a story that's being told here. Ever since 2014, we've really started to see, a heightened awareness that opioids in particular are becoming a problem in our country, but substances in general have been for a very long time. What we see now is with COVID, basically substance use and mental health are kind of taking a hit once again. So we were starting to tail off a little bit with the opioid deaths. And also we were starting to see decreases in prescriptions for medications that were opioids. But now what we're starting to see is with the COVID pandemic, that trend is starting to go back up with those deaths. So they're actually forecasting between the years of 2020 and 2029, over 1 million deaths just from opioid overdose. So You can see the figure on the screen here. And that's quite staggering as we look ahead here and hopefully knowing that's the forecast, we can get ahead of that and prevent that number from being quite so large. Additionally, you know, right here at home in Michigan, what we've seen, and we all know statistics sometimes lag behind a little bit, but from the year 2019 to 2020, we saw a 3.65 increase in the number of overdose deaths from opioid use. And so, you know, it certainly is not a problem that's gone away. And right here in our own backyard, it is continuing to increase. It's something that we need to be, you know, aware of. And that's what our goal is as a group, is to address that and trying to get ahead of that. Lastly, what we can see is we're serving a 3-county area of Mecosta County, Osceola County, and Newaygo County. And what we've seen over the year, basically the 1-year period from May 2020 to April 2021, were 26 overdose deaths in our county. So that's truly in our backyard. And so that really is why we're here today and what we're trying to address. Everything that we address builds towards reducing that mortality and saving those lives. So Cameron, who are we? Gail mentioned we are the Central Michigan Recovery and Education Network. We haven't always gone by that name though. We were founded as the Rural Opioid Task Force back in 2016, which really stemmed from a conversation between 2 deans here at Ferris State University, just basically saying, you know, perusing through literature and seeing that there was a problem with opioids and that Michigan wasn't immune to that. It certainly affected us as well. So through those conversations, a partnership and collaboration kind of formed, and we created this task force to see what we could do to address that opioid problem here at Ferris State University and also in our community. So really the first big success that we had was getting access to Narcan, which is an opioid reversal agent or an antidote, if you will, and into all of the security vehicles here at Ferris State University. Conversations continued after that. You know, the opioid task force realized that this wasn't just a Ferris State University issue, that we wanted to branch out into the community. And they started to have these same conversations with Spectrum, with the District Health Department number 10, and with the community mental health here for Central Michigan. And so that collaboration kind of formed with those 4 primary partners who are still the founding partners of our group here today. And basically what they did is they looked at Mecosta County first, so kind of made it a county-wide initiative and looked at things that were happening, looked for patterns and looked for different ways we might be able to solve this opioid problem. What they did is actually apply then for a grant through the Health Resources and Services Administration. And so the opioid task force then became the Rural Opioid Prevention Network at that point in time through a 1-year planning grant through HRSA. That planning grant was developed to strategically plan what we can do in our counties here to help with this problem. We are now known as Central Michigan Recovery and Education Network. And so the names have changed, but the focus hasn't. We just have changed the name as we've changed kind of the overarching goals that we have here. So we became Kimbrin whenever we got an implementation grant. So you can see on the side here, HRSA funded us for a 3-year project for $1 million over the 3 years to address this issue. But we've expanded now from just Mecosta County to Mecosta, Osceola, and Newaygo. Now we are almost officially halfway through that 3 years, and we're starting to really see progress in the communities. And it's been quite exciting for us to kind of go through that journey. And we're excited to look ahead and see what we do with the second half of this grant and beyond. You can see our mission here, but the things I want to point out from this mission are that we are here to amplify things that are already in place. So Cameron doesn't want to go out into the community and compete with anything that is already succeeding or serving the community. What we do want to do is provide education, resources, and collaboration between those service providers. And the things that we focus on are education, prevention, treatment, and recovery. And you truly have to have all 3 of the prevention, treatment, and recovery. You know, if we focus on only getting everybody into treatment and we didn't have any heightened emphasis on recovery, then we'd have a lot of people that were seeking recovery and nowhere for them to go. And so we really are trying to hit this at all angles to make sure there's a continuum of care for these individuals who are struggling from substance use disorder.
It truly does take a village. We started out with 4 partners, and now we're up to 28 partners across the 3-county area. All of these folks are folks who are working in and around substance use disorder. Some of our partners are Spectrum Health, which actually has facilities in all 3 counties, Community Health Department, Central Michigan, District Health Department number 10, District Health Department, Central Michigan, which covers Osceola County, 1016, which offers substance use services in Mecosta, Osceola County, Arbor Circle, which offers similar services in Nuevo County. We work with the public schools in the areas. We work with medical practices. We are working with Sisters of Sobriety and other recovery houses. So a multiple group, as well as some pharmacy chains, family healthcare, which you'll hear more about that project from Jonni. And so many places. And so we're really excited about that. And what we've learned is over our time now, we're starting to be known and we're starting to take action. And people are now coming to us and say, can we partner with this? Or if we reach out, they're like, yes, we want to help. We want to be a part of this. Some of the projects that we're working on right now that are making a difference, Scott mentioned that Narcan is that reversal agent. And you'll see the next bullet says anti-stigma education. There's a lot of stigma around the use of Narcan. It's that reversal agent, and some folks believe that it encourages people to continue to use drugs because they have already access to a way, if they overdose, to reverse it. That's not necessarily true. And so what we're trying to do is an awareness of that, and an awareness that it doesn't always reverse with 1 dose. It may take up to 4 or 5 doses distributed in 3-minute intervals for that person to actually respond to the Narcan. So we're working with MOSAC, which is the Mecosta Osceola Substance Awareness Coalition. And they started, like Cameron did a few years ago, as Scott mentioned, getting Narcan out in the community to all of law enforcement. And so they all carry on their belts in Mecosta Osceola County and have it at ready access. We are working with the MOSAC, and the DART is the Dial-A-Ride Transport area in Mecosta County, specifically in the Big Rapids area. And they agreed to allow us to put Narcan signs on their buses for 3 months. We're doing February through April, and then we'll do it again later in the year to help us spread that awareness to save a life with Narcan. And then we're working inside the jails in the counties. And we are now training each of the inmates on the use of Narcan, and then they can have a Narcan kit when they are discharged if they ask. So we've been successful in 1 county, and we're meeting with the other 2 counties in March to be able to spread that. Our future plans are that we want to get a Narcan kit in schools and churches. That's one that's mounted on the wall right by their AED and their safety kit, so that they have access if they need it. We'd also like to be able to get it into area gas stations and other places, bars, where sometimes people use and an overdose can occur. And so we want it to be at the desk. So those are some of our areas. For the stigma, it goes farther than just the use of Narcan. Stigma just about these are bad choices that people make over and over. And if you were trained in this area prior to 15 years ago, that's how you were trained. And now we realize so much more about the brain and the impact that substances have on the brain, and the brain changes to the fact that for some people that brain change creates that craving that it's more important than anything else in life. It's more important than food, it's more important than shelter, it's more important than a job, it's more important than family. That craving controls you. And so it's working with people to understand that. And so we're starting this. We have a graduate student who's doing her capstone project. She's a master's in healthcare administration student, and she's built an anti-stigma toolkit. It's a virtual training kit We're having it trialed right now by the Spectrum Health Addictions Department. And so it's intended for individuals, or there's a module that we can use for corporations to go through and do the training with their staff, and then actually look at their website and all their brochures to be sure that they're changing out any stigma language, so that we start to really train communities. And so we will be bringing that once we have the project complete to FSU and taking it out into the community. And then the College of Pharmacy did a wonderful SUD event just a couple of weeks ago, realizing that we really need to train individuals who are licensed and who are professionals, the impact that substance use disorder can have on their future and their livelihood. And so there was a great training, and it went over well, and we're hoping to replicate that in other programs across the university.
Now, as we talk about substance use disorder, addiction, opioids, Narcan, I'm sure that you all have heard these words, and there is some sensitivity that goes along with that. As we talk about stigma, sometimes individuals who are seeking treatment or who wish to seek treatment might feel judged. Just conversely, the healthcare providers that are offering those same services might be a little bit sensitive towards those topics, or not know how to approach those as well. So one of the things that we've been doing this back in 2021, we started actually in the summertime, was developing some very quick modules to train healthcare providers to have conversations with patients, to discuss things like opioid use, maybe opioid overuse, in particular focusing on naloxone in the pharmacies. So the pharmacy is the last stop where the patient might leave with prescription opioid medications. And it's also an opportunity for the healthcare system to leave them with something that can save their life should them or another person in the home get a hold of that medication and use it incorrectly. So what we did is we actually developed these training modules and then surveyed some pharmacists who actually took the modules. And we've seen positive changes in perceptions and attitudes. It's still a work in progress. Pharmacy was kind of shaken by COVID as well. And so we're reaching the pharmacists as we can, but also noting that just like all of healthcare, they are fairly overwhelmed right now with offering other services. So it's an ongoing adventure that we're working on. And certainly we're trying to get out into more and more pharmacies to help that kind of last line of defense, if you will, to be equipped to have that conversation with patients and for it to not feel awkward or shaming or judging in any way. And the last thing we want to talk about is our at-home drug disposals. And so some of you may be aware of drug take-back days that happen in the community. That's a way to kind of go and get rid of any unused medication in the home. There are some drop boxes where you can do this in local pharmacies and also at the law enforcement agencies. But there is still some of that stigma associated with that. And some individuals don't wish to go do this in a public space where they're going to be visibly seen disposing of medications. So one of the things we've looked into is how we can do this more privately and discreetly, but also still safely. We have an NPH PharmD dual enrolled student who did a capstone project, basically just assessing the competencies and knowledge of the public here in Mecosta, Osceola, and Newaygo counties to kind of get a baseline understanding of how they currently get rid of medications and asking different questions about that, but also just their general knowledge about safe drug disposal as well, and what they think is safe, what they think is easy, things like that. Then what we did is a very short intervention. So literally like a 2-minute video describing some safe at-home mechanisms for disposing of medications and asked the same questions. And what we saw was statistically significantly an increase in comfortability with disposing at home and the belief that it's easy to get rid of medications. So what we've done with that project is really, and it's still kind of being finalized right now, but we've kind of been able to determine that a small intervention of education might make a big difference for getting these unused medications kind of out of those cabinets, if you will, and safely disposed of. And to pair with that, Cameron has purchased many Doterra packets. So this is an at-home disposal pouch that you can use. It's very simple. You just pull the tab off, drop the medications in. There's some activated charcoal inside. Add a little bit of water, seal it, and then it takes care of the rest. It gets completely rid of that substance. It makes it inactivated. And if you try to readjust that, you're just going to vomit because of that charcoal that's inside. So it's a safe way. You can throw it in the regular trash.
Families Against Narcotics. Several years ago, Judge Linda Davis in Macomb County sat at her bench and was sentencing people who were before her with SUD, OUD types of incidents. Only to realize when she went home one weekend that she had a child who was impacted by this, that she had no idea until it was so obvious you couldn't miss it. She tried hard to get her into systems here in Michigan and realized just how challenging and difficult it is for someone, even with her education and understanding, to get help for her child. So she did receive help for her child. Her child was taken care of, but not in Michigan. And she then decided something needed to happen. She stepped down from the bench and formed Families Against Narcotics. This is now recognized after 10 years by the state of Michigan as a budget line item. There are chapters all over the state, and we are starting a chapter here in Mecosta, Osceola County. These, the services from Families Against Narcotics, or FAN as we call it, are offered through volunteers, many of them referred to as angels by training, with multiple programs, peer recovery that's available 24/7 for as long as a year at no cost to the individual if they would like it. Hope Not Handcuffs is one of the programs we want to start here. And that is a program that allows people that want help to approach any law enforcement agency and simply say, I need help. And then they contact FAN, and a FAN angel will come and help them seek services that are available within the community and assign them a peer recovery coach that can stay with them and work with them if the individual wants it, until those services are well underway and beyond if they'd like. There are other programs, some family programs, and other things that we'll be working with. But this is something we're bringing, and we're currently forming a chapter. We said, how can you help? If you would like to learn more about FAN or be involved in FAN, reach out to Scott or myself and we can help you get connected.
All right, so next steps and ways to get involved, should you be interested. This is kind of where we've discussed where we're going and where we're at. This is where we're going. And you can see kind of the buckets along the top here. Things like we talked about, prevention, treatment, recovery, but also community and sustainability. I did mention that our grant ends in 1.5 years, and we certainly want this work to continue and live on much longer than that. So as we move ahead here, the areas of focus are here on the screen. For prevention, it's going to be continued harm reduction strategies. Now that ranges in a variety of mechanisms, things like the Narcan that we've discussed already, clean syringe access for anybody who might be using syringes. We want to prevent other diseases from occurring if somebody is using that way. Additionally, the safe drug disposal that we've discussed, and really trying to figure out how we can target these individuals for treatment. So that's going to be looking at things that we're currently doing for screening, and then looking for opportunities that we might have that we're not currently utilizing. Reducing stigma. And again, this is everyone is affected by this. It's not just for the individuals. It's not just for healthcare workers or organizations. Everybody is affected by stigma. We probably all felt stigma in some way or another. One of the best examples I have of this is if you're in a public space right now and somebody starts to cough out loud, you know, there's this weird feeling of, do they have COVID? You know, is this person coughing because they have COVID? That stigma is the same thing for an individual who may use substances that's seeking treatment. You might have those same types of feelings about this person. And so we're trying to make this feel more like a disease, because that truly is what it is, and treat it similarly like we would to diabetes or any other complication. Enhanced telehealth medication counseling through telepharmacy. And I'm going to leave that one for Jonni here in just a moment. So I'll tee that up for her and she'll talk a lot more about that. Now for treatment, we're looking at medication-assisted therapy. Now, one of the best evidence-based practices is to help somebody in treatment with opioid use disorder is to help them wean off of that by the utilization of medications. And so we're trying to make this more prevalent in our area. And we're doing that through education, through collaboration, and also through some billing and coding sessions to make sure that these practices can do this and still and not lose money, because that's going to be a barrier if they do. We're looking at collaborative work to increase peer recovery. So utilizing those individuals who are already in recovery to help others to seek recovery. And then collaborative work to increase navigation. So that kind of goes with the screening I was saying before. We have a lot of opportunities to increase our navigation, where when we identify somebody who may benefit from treatment, actually plugging them into the treatment, helping them to find the resources that exist. Because there are so many groups that are doing so much work, but through our collaboration, we've learned that not all of them direct one another, patients or individuals to one another. And so that's something we're focusing on as well. Now for recovery, we're looking at enhancing the recovery options. So that's going to be, how can what services exist for recovery? Is it peer recovery options, family recovery options, recovery housing, where you actually go to a residence? But we're also looking at helping with affordable housing for these individuals to help them to truly get that fresh start and get away from the old patterns so that they do have a fighting chance to succeed with their recovery journey. And then helping them to seek employment as well. It's really hard to get back on your feet if you don't have a stable source of income. And so we're looking at this really holistically. For community, it's really just engaging with the community. So we're going to be having some town halls through our Families Against Narcotics chapter. And we're out in the community with some of our partners and collaborative efforts as well. But we're also looking at community here at Ferris State and looking for opportunities that either we can help or that others that are working in this area can help with us as well. And then lastly, for sustainability, does come down sometimes to funding. So we're always keeping our eyes on the horizon for opportunities to enhance services through funding, similar to the grant that we have and the one that Jonni will talk about today. We've got the chapter for Families Against Narcotics that we're starting here. Once that's up and running, that's going to offer some great services on an ongoing basis for the rest of the community. And we are engaging potentially with Nuevo to try and either get them involved in this new chapter or to see if they want to revitalize a chapter that used to exist there. So I know that's a lot of information. We will take questions at the end. I want to be respectful of Jonni's time for her portion of this presentation. This is our website. If you want to learn more about Cameron, please visit it. And as Gail mentioned, reach out to either of us with any questions or comments. With that, I'll turn it over for Jonni to talk about her pharmacy telehealth grant, and we'll come back for questions at the end.
I'm Jonni Williams. I'm a pharmacist with Family Healthcare Pharmacy and Grant. Family Healthcare Pharmacy is a federally qualified health center, so it's not for profit, and we typically are located in rural, underserved communities. We have a lot of patients without insurance. We have a lot of patients who are Spanish speaking only, illiterate, a big variety of patients, and we have a couple of different family healthcare locations. One is actually here in Big Rapids, but it doesn't have a pharmacy, it's just the medical office. So it's more of a clinic setting where we're connected with a doctor's office, to eye doctor, dentist, and then the pharmacy as well. So it's a really unique place to work, and it does really help a lot of patients who have difficulty going to their doctor's appointment, and they can just go to one appointment and see all the above instead of having to go to 5 different places. And Family Healthcare became a partner with Cameron, and they reached out to us for specifically the grant Telehealth in rural Michigan, increasing access to substance use disorders and opioid use disorder services in Mecosta, Osceola, and Nuevo counties. So we do have family health care in Mecosta and Nuevo counties. Our project studies the access and barriers to treatment for patients with substance use disorders. It looks at the potential for telehealth medicine to be implemented for treatment of these patients. And it also looks specifically at the role of pharmacists for this telehealth option. Some of the barriers to treatment that we have seen, and this is through studies through the SAMHSA organization and a ton of research, they have transportation issues typically. Some of them don't have licenses, or some of them, just can't get to where they're going because there's not a lot of options healthcare wise in the area that they're at. There's a healthcare provider shortage in most of rural Michigan. As Scott and Gail talked about, the negative stigma of treatment a lot of times prevents people from coming and seeking treatment. They're afraid of getting treatment because they need the addiction so badly, just like Gail was saying, it's life and death for them. So a lot of providers believe that patients are unwilling to recognize there as a problem, which I do believe can be an issue, but I think most of the time it's the willingness and the wanting to get treatment and get away from that addiction. The cost of care, a lot of the patients don't have insurance or don't have a job to afford insurance. Availability of care and scheduling constraints, the management of care and their medications. A lot of times there's only a handful of medications that can be used to treat substance use disorders, and they might not be available at certain pharmacies, or there's an ordering issue with them. There's so many times that these medications take more than a day to get into the pharmacy, and then the patient's sitting there without their medication and no other option. And then the coordination of care between providers, and that's really something that we see an issue with. If a patient's seeing multiple providers, then one might be prescribing a narcotic for a surgery and the other one's trying to treat an addiction to a narcotic. So that's very important as well, since we don't have a connected medical system that all providers can access. So telehealth medicine is something that we looked into with this grant. And according to the Mayo Clinic, telehealth is the use of digital information and communication technologies, such as computers and mobile devices, to access healthcare services remotely and manage your healthcare. And probably a lot of you have used a telehealth service sometime during COVID, because it's really taken off during that time frame. You either have a phone call visit with your doctor, or sit down at the computer and do a video chat with them. According to SAMHSA, which is the Substance Abuse and Mental Health Service Administration, about 80% of rural communities in the US are considered healthcare professional shortage areas. So that definitely includes Mecosta, Osceola, and Waco counties. The benefits of telehealth, and this has been studied regularly over the years, benefits of telehealth include potential increased access to care, because the provider doesn't have to be in the same location as the patient. Convenience of scheduling, reduced stigma, because the patients can do this in the privacy of their own home or in a private location. Reduction in healthcare provider shortages, and coordination of care between patients and multiple providers. So if you have somebody taking the lead on this patient's care, they can then contact the other providers and make sure that the care is coordinated and working the best for the patient. Some of the barriers to telehealth are internet access issues, the locations that they're offered, the number of providers that are willing to offer telehealth, and reimbursement or coverage from insurance companies on both the provider aspect and the patient's point of view. Research has shown no significant differences with patient and provider satisfaction rates when using telehealth. So by using telehealth, we're not reducing the amount of care that the patient's getting versus an in-person visit. And both providers and patients agree that that is the case. So what could be the pharmacist's role? We are the most accessible healthcare professional. There's 24-hour pharmacies, there's pharmacies opened after 5 p.m. All these places, you either have the pharmacy or you go to the emergency room a lot of the time. So we are available in all the areas, and most rural communities have a pharmacy, and that's where the patients get a majority of their care from. We can provide medication education and management. We are the experts in the actual medication department, and we can help with making sure the patient is being adherent to their medication, making sure they're picking it up on time. Most pharmacy systems already have computerized adherence monitoring programs. So we can look at that and say, okay, this patient was late to pick up their medication by this many days. The goal for most adherence for typical medications, like your maintenance medications, would be 80% of the time taking your medication exactly how it's supposed to be taken. With substance use disorder patients, we would hope that would be a little bit higher, because anything lower than that could greatly increase the risk of relapsing. We can provide screening tools. A lot of pharmacists have access to, depression screening tools, suicide screening tools, and that takes up a lot of time at a doctor's office visit. So we could potentially provide that service. We can connect patients with a variety of support services, including the peer support groups that Scott and Gail were talking about. So those are people who have been through it and know how to get access to services. And we also are aware of the suicide hotline. We can refer patients to them if there's that issue. We have knowledge of the treatment programs and facilities in the areas. We have access to recovery coaches and other healthcare providers. So we really are the middleman between the patient and the doctor, or the patient and the nurse practitioner, whoever they're getting their care from. So our project goals, it is a 2-year project and we're finishing up year 1 right now. In year 1, we wanted to collect baseline data through surveys, and we did that through 3 different surveys. We wanted to share our data analysis with all the Cameron partners, and we wanted to establish a residency program with family health care through Ferris State University, so that way we could sustain this project and have, that's where the additional healthcare provider is going to come from, is these pharmacy residents. We want to share our project with the community through town hall meetings and develop a strategic plan to implement this telehealth program. In year 2, that's when we would want to actually give that option to patients of the telehealth medicine. And that we would start that with family health care, because we already are a partner, we already have telehealth services in place. But family health care right now doesn't offer telehealth for substance use disorder, opioid use disorder patients. So that would be an expansion of that program. But we already have the technology, we already have the space. So that's a really good place to start. And then Ferris State University residency program will start, and the resident will be involved with offering those telehealth services as well. And we also want to decide how we can sustain this project for longer than the 2-year grant period. So our 3 surveys that we conducted were the pharmacy telehealth baseline survey, and this was reaching out to pharmacists in 3 counties, included Meyer, Walgreens, Rite Aid, Hometown Pharmacy, all the typical pharmacies that you would think of. And then we also reached out to healthcare providers in the 3 counties, including doctors, nurse practitioners, PAs. And the community opinion survey is the survey that we wanted to go out to community members to see their side of things. So the first survey was the pharmacy telehealth baseline survey. We surveyed 12 pharmacists, 3 in Mecosta, 2 in Osceola, and 7 in Newaygo counties. 11 of those pharmacists were retail pharmacists, and 1 was an independent pharmacist. 100% of those pharmacists dispense medications to treat substance use disorders and opioid use disorders. 100% of them do not offer telehealth services at this time. 66.7% would be willing to offer telehealth services for substance use disorder, opioid use disorder. So the pharmacists in the area they're willing to help, they just don't know how to do it at this time. So the barriers to telehealth that were identified by the pharmacists. Time constraints was a big one. 11 out of 12 pharmacists said time constraints would be an issue, which we know, as Scott was saying, pharmacy is taking a big toll, or COVID's taken a big toll on pharmacists, especially retail pharmacists who are offering immunizations, testing, and dispensing medications all at the same time. Worker shortages goes along with the time constraints. We wanted to see if pharmacists believed that providers would not be willing to work with them, and only 2 of the pharmacists thought that might be an issue. Only 1 pharmacist thought that the pharmacy staff would be uninterested in that. 3 thought patients might lack interest in telehealth. 2 said cost may be an issue, and then this one really hit home with us is 11 out of 12 pharmacists said that they need more clinical training on substance use disorder and opioid use disorder treatments in order to feel prepared to offer telehealth services or any type of counseling services to patients. And I agree with that. And I know Ferris has improved recently and tried to get more education out there, but that was definitely a very specialized training when I was in school at Ferris. And it's not something that's separated from all of the other training. So it just kind of goes by the wayside with everything else that you learn in pharmacy school. So I agree that that is very much needed before we can be fully prepared to offer any more services to patients. The lack of equipment, that would obviously be a huge barrier that we'd have to implement. And the lack of space for equipment. A lot of retail pharmacies have very little free space.
You have 10 minutes left.
Oh, thank you. Sorry. Does that include question time?
No, 10 minutes total.
Okay, perfect. Okay. The community healthcare provider survey was to the doctors in the areas. We had 10 healthcare providers complete the survey. Only 3 currently consult clinical pharmacists for patient education and dosing on substance use disorder medications. 75% of them said both patients and doctors would be willing to work with pharmacists. 50% use telehealth for substance use disorder, opioid use disorder patients already. And of the 50% that don't use telehealth services, the barriers that they identified, the biggest one of that was the lack of providers that are specific to managing substance use disorder and opioid use disorder. So it really goes along with the lack of the healthcare provider shortage that we're seeing. And then random stuff is like elderly patients are not internet savvy or the internet access, and physical exams are needed for urine drug screens, that kind of situation as well. So of the 50% that do use telehealth of those providers, 57% say patients do benefit from increased access of treatment. And 43% said that there are fewer missed appointments with offering that telehealth service. So you can see some of the barriers to telehealth that the providers identified there, with the biggest being internet connectivity and technology difficulties. So that is something we would definitely have to address down the road. The community opinion survey again went out to community members. It is still ongoing right now. We did have difficulty reaching our target group. We had a very large amount of patients take the survey, but most of them said that they are not currently in treatment for substance use disorders. A lot of them said that they knew someone who is, but they weren't able to complete the survey because we wanted to target specifically those in treatment for substance use disorders. So we are currently distributing a second round of those surveys at Samaritan Addiction Recovery Services, Forgotten Man Ministries, and 1016. And those organizations have much better access to the target group of individuals we're trying to reach. The survey asks about barriers to access of healthcare. If the patient has ever used telehealth medicine, what benefits or barriers they perceive to telehealth, and they're interested in using it in the future. Also interested in working with pharmacists for that program. Our future goals of this project is to present what we have found to town hall and city council meetings. We have to develop the strategic plan for year 2. We're going to implement the telehealth services for substance use disorder patients at family health care. And we're going to recruit pharmacy residents, which we're currently doing interviews for them for this program, and ideally increase the access to care and improve the process and outcomes for patients with substance use disorders, opioid use disorders in the 3 counties. And those are my resources. Okay. Thank you. We can take questions now. Yeah.
All right, so what questions do you guys have, or anybody on Zoom as well? Sure.
I have a question. If you're talking about somebody with like some type of a pain, I don't know what illness, disease, that's taking pain medicines for that, how do you go about? I'll just be specific. So my mom has fibromyalgia and is on a lot of very strong medicines. And, to talk to her, it's just that's the only way she can survive.
Yep.
And the doctor just keeps prescribing, and the pharmacist keeps filling. So how do you get to where you can find one person to coordinate things and to help you? Like you said, there's other drugs they can replace it with, so they still can get relief, but in a different way. How do you even start with a process like that if somebody does that?
It's a great question. So, I think, the providers, first of all, would be a good resource to just start the conversation with. If you don't express an interest, unfortunately, sometimes we don't ever, the opportunity is missed. There's this concept called ALTO, which stands for Alternative Drugs for Opioids, to Opioids. And so basically that means that there are other options for both pharmacologic, so medication-based treatment, and non-pharmacologic, so more lifestyle-based treatment. Now fibromyalgia is tricky. It's very painful and sensitive disorder. And I'm sure there's a little bit of an element of fear with that too, if you start to pull away some of those medications. And so I think there are some resource guides out there that providers could use, pharmacists can assist with, that can help that process, but certainly the patient, we would want want to be involved in that as well.
Right.
Because whatever we decide, we want them to be able to follow through with, otherwise there was no point in trying at the beginning.
And also if she wanted to, whoever her local pharmacist is or whoever she gets her pharmacy medications from, she could discuss with the pharmacist and say, hey, if she is concerned about taking all these medications, what do you think we could do to try to reduce some of those or wean me off of some of those medications? And the pharmacist can then reach out to the provider and say, hey, so-and-so came up to me and was concerned about their medication regimen. This is what I think we could potentially do to help reduce some of the medications that she's on. What do you think? And then it's the team collaboration, and then it's both, the pharmacist saying, I have this report saying she gets this, and this medication. And these are the interactions between those medications that we're concerned about. And then they can provide a bigger access to the provider as well.
So maybe starting with the pharmacist.
I think that would be a good idea because
Probably easier to
Yeah,
access that
okay.
conversation. with the
Yeah.
pharmacist.
and then they can look at all the medications and, look from all the providers if she sees multiple, providers. And then they can say, yeah, you're right, it would be better to try to reduce this because coming from a pharmacist perspective, a lot of times when I see a patient that's been on the same medication regimen for a long time, it doesn't cross my mind a lot of times that the patient might want to change that. I keep in mind that maybe the patient's happy with that regimen, and if it's well, controlling their pain well, or if they're satisfied with it and I don't see any big red flags, then I'm okay with it. I don't want to, get them scared about reducing their pain medications or causing them pain. So if she's coming to the pharmacist and saying, this is my concerns, then the pharmacist can really take a closer look and be like, okay, well, this is great, you're on board with it, let's talk to your doctor and try to reduce that.
And actually probably the issue is she doesn't see any problem. So, okay.
It's a difficult conversation to have, especially as a family member or a friend. And I think just the more education and awareness that gets out there is really going to help with that as well. So that's why we do have a big aspect of community within our product as well.
That's true. Thank you very much.
Yeah, thank you.
No other questions are coming so far.
Okay.
All right, well, if you don't have any other questions, that gives us an extra 2 minutes to transition to the session. So thank you very much.
Thank you guys.
Thank you all for coming.
Few minutes.
They said, great job, everyone.
Oh, thank you.
Thank you very much.
Awesome. You want me to close that out, the presentation?
No,
Okay. All right, well, thank you so much, appreciate it.
can you put the correct website?
Oh, yeah.
Yeah, it's very, I'm very passionate about it. Being part of it now. I used to work for Meyer and,
I'll see that up there.
it's
Is that
very
the
busy
correct
pharmacy.
website?
Oh,
Yeah.
no,
Busiest
hold on.
ones in Big Rapids. I was actually at Meyer in Big Rapids. And you don't have time for any extra projects or anything, so it's nice to
Well,
know.
do you think that, that providers and pharmacists are more willing to look at telehealth because of COVID?
Yeah, we must have just
Yeah.
missed each other,
And
but
did ask
I was
that
down
in
in
my survey
203.
that,
Like,
how long
isn't
do
there
you
a
follow
room
up?
monitor? Isn't there anywhere here? And then I happened to look at a schedule. It's like, why did I think I was in 203?
Oh.
Keep using it since so, and where are the insurance companies?
We're having some, the
Right,
slides
and
went
most of them cover
blank
from what
here,
I can
so I
tell.
just put it into the chat for anybody.
Okay.
Thank you.
Hopefully COVID's gone.
From what we understand.
Yeah, I was wondering, I got here
Otherwise,
actually in pretty good time.
Yeah.
Yeah.
Online and social.
So I was just kind of in here just hanging out,
Yeah.
checking the
I
advice.
was here, but I got a 4:30.
So,
yeah. And so
Right,
I was
right,
like,
I hope
I
it
don't
will,
know where he is.
or
He's
we
never
can get
late.
to the
Yeah.
point of also
Johnny
recommending that
and I
it's
said,
just
yeah,
offered
this
as
is
like
where
free.
you are. And then I looked at this.
Yeah,
They're like,
was.
oh, we're not
That's
in here.
getting used to like, this is how we
Pick up my stuff
incorporate,
and go,
Yes.
we incorporate the treatment.
Yeah, I was thinking
And we don't want to replace,
I didn't
you
want
know,
to
those
text you too
required
early.
ones
because
where you were.
I didn't use my
Yeah.
phone because
in
Tom
person
brought me
meetings
in.
are
Oh,
right, so
yeah.
we want to supplement that to really
And,
reduce